Hello, Roxana. Hello, Ajay. Hello, everybody. Can you hear me? Oopsie. Okay then. So welcome to the Andreas Grunsig room here in the Thorax Center in our cath lab, where we have selected a patient, a complex PCI patient. I will not do this by myself. I have an expert team next to back me up. Wijnand den Dekker is my senior staff member colleague. Then Linda Josias is our head nurse. There is Sanna, another nurse who will take care of the patient while we're working. And then we have from the technical support, Lianne and Quinten. So that said, Wijnand, maybe you can describe the patient in front of us.
Okay, thank you very much for the introduction. Also a warm welcome from my side. So I will introduce the patient. It's an 82-year-old male patient with this history, amongst them a transient ischemic attack, and he has risk factors, hypercholesterolemia and hypertension. And next slide. He was referred to another hospital because of progressive dyspnea on exertion, near classification 3, and then he had a systolic murmur on physical examination. He had a normal EKG except for first-degree EV block, and then on echo he had a good systolic LV function, but a severe aortic valve stenosis with a maximum velocity of 4.4 meter per second, and a peak gradient of 77 mercury, and then the area was 0.7. So he had a good kidney function. Next slide. And then in the workup, there was an angiography done in a referring hospital, which you can see here. There is some intermediate stenosis in the right. And there is, on the left, there's a calcified stenosis in the proximal LAD, also in the distal left main. And it is difficult to interpret the stenosis in the high diagonal or intermediate branch, as you can see. And the next slide. So the STS score is 1.5 and the Euro 2 score 1.8%. And if you calculate the syntax score, you end up with a score of 41, which would mean that you would refer maybe the patient for a cabbage. However, if you also take the clinical parameters into consideration and you calculate the syntax 2 score, then you come to an equal score. So even PCIs may be a better option for this patient. So there was a heart team discussion, and it was considered to be a high operative risk, and there was a consensus for staged intervention, for a PCI of the left main to the LAD, and the evaluation of the diagonal and the intermediate branch, and then in the second stage do the TAVI. So Nicolas, maybe you can tell the setup we have and our approach for this case.
Well, are there any comments from the chairs or the panelists?
No, this is a difficult case, obviously. You have aortic stenosis on top of a calcific. It looks like a calcific lesion. I can't see it very well. You'll show us the anatomy a little bit better when you do your guide shots for us. But let's hear, Holger, how would you approach a case like this? Are you open to this, or would you really push for cabbage ABR?
No, I think we would have made exactly the same decision to make a stage procedure and also go for TAVR, not to go for surgery. So we would exactly do the same at our institution. So it looks nice, and I think it's a correct decision to go for an interventional approach in this specific patient.
What about the one question that everybody will have is, how severe is the aortic stenosis? What's the hemodynamics? And would you consider to support your PCI if you believe it's going to be complicated and long? Would you be open to a balloon valvuloplasty just to support you for your PCI? Or so that's a question that sometimes comes into play when we are having these discussions.
Yeah, I think as everything is determined by the LV function. If it's preserved LV function, then there is some leeway, although it depends on the complexity of the PCI that you are performing. So, for instance, if there is a high likelihood of complex PCI, including some kind of atherectomy, then that might be an argument to consider at least balloon valvuloplasty prior to the complex PCI. In this particular patient, the ejection fraction was normal, was above 60%. The Vmax was 4.4 meters per second, a mean gradient around 65. So I think we felt comfortable with treating the coronaries up front without doing a prior valvuloplasty. That said, anything can happen. So we do have everything in place just in case some unexpected hemodynamic changes would occur. So let me bring you back to what we've done so far. So this patient came to the hospital today and said, listen, they did a radial angio, no radial access for me, just go femoral. Well, I talked to him and I said, listen, I want to go through your wrist because, you know, I want to have clean femorals when I do the TAVR a couple of weeks from now. So I convinced him for an ulnar access. So that's what we did. We have right ulnar access, and I also used a sheetless system. So a 7.5 French sheetless system by Asahi. And I think these sheetless technologies are really game changers for complex PCI through a radial or ulnar approach because the profile of these catheters is smaller than 6 French. So basically, it rules out important spasm, at least in males. So we went in with our 7.5 French sheetless SC 3.5, which is an EBU shape equivalent. And we started with a couple of angiograms. And maybe we can start with our spider view. And here it is. Is it? Can you identify the calcium in the left main? There is a circumflex that is not. It's relatively small. He had a very dominant RCA, which only had luminal irregularity. So that was also an important aspect in the decision-making process here. And then we were unclear about that intermediate branch, or is it the high diagonal branch? If that ostium is, if there is a lesion in the ostium or not. And then there is disease in a second diagonal, but we considered that second diagonal, relatively small. It's a 2O vessel, so we would prefer not to stent that. And then we see that the calcified disease extends from the left main into the mid segment of the LAD. Maybe we can show the AP caudal.
This really shows the calcium, severe calcifications.
Yeah, you can definitely appreciate the calcium before the contrast is given. Next one that's the cranial. That's an air shot because of breathing. And then this is the cranial, an RAO cranial shot, where it's maybe a little bit more difficult to appreciate the left main disease, but you can see that the disease in the LAD extends beyond that diagonal branch. So based upon these pictures, we were a little bit concerned, or at least we did not know what the diagonal, that high diagonal would look like. So we decided to do an OCT of that diagonal. And well, let's show it, Quinten. So this is the OCT from that big diagonal branch, and we did also co-registration, OCT co-registration, nicely done by Quinten. So you can, as you are pulling back your OCT catheter, you can track by fluoro where you are on the fluoroscopy. So, Azeem, if you have a question?
Azeem, go on. I'm sorry, I didn't see your hand raised.
I was just going to ask Nicolas, in these cases where patients have severe aortic stenosis and you want to do complex PCI, in which situations do you think it's worthwhile performing a BAV before the PCI?
Well, if the LV function is decreased, when it's an unprotected left main, or when I anticipate very complex PCI techniques. So then I would do the BAV up front in the same session as the PCI, but before I touch the coronaries. And I would also do that with an undersized balloon just to make sure that I don't damage the leaflets, the valve leaflets too much. What I also often do then, especially if the LV function is depressed, then I would follow the balloon valvuloplasty with the introduction of an Impella catheter, because you then already have crossed the aortic valve. You have a wire there, then you just exchange your 035 wire for an Impella wire, and then you can insert the Impella.
Okay.
So basically, before we go to Atlanta, I want to show you the surprise that we experienced. Based on the first OCT, is this the second one or the first? This is the first. So let's go now watch at this together. And this is the second OCT, but we also saw it on the first. So can we do the pullback there? Just press play, and now we're coming from the LAD towards the left main. And so bear with us for another minute. What you'll experience is there is, of course, spread out calcium. It is 180 degrees. Here it becomes 270 degrees, 270 degrees, 270 degrees, and then there is thrombus. So we experienced thrombus, and this is a little bit of a strange finding because the patient had no acute coronary syndromes or anything, so he had progressive dyspnea on exertion, but no ACS. And this dramatically changes our strategy. So now we are faced with a coronary that is heavily calcified with 270 degrees of calcium, but also with thrombus. And at least in my opinion, that rules out atherectomy. I don't know what the panel thinks of that.
Okay, well, go ahead.
It looks a little bit like it could be, calcific nodule. Actually, if you look back on that part of the OCT, it's adjacent to the area with the calcium, and then there's actually that cookie cutter appearance within it as well, which would fit with the clinical picture a little bit better too. If you see maybe if you spin on that, if you spin the orientation of the OCT.
Put the OCT again on the main. Yeah.
See, because it has the same exact density as the surrounding calcium there.
This is calcium, I agree.
Wow. Okay, that's...
But more proximal, there was one at the bifurcation, I think. That's where you were a little bit puzzled.
Oh, come on.
Yeah, so what we're going to do is we're going to go to Atlanta while you guys figure this out with your experts there, because it's harder to see it, and maybe when we come back, you can put it up and tell us what you're thinking. So we're going to go to Atlanta, and then we'll come back to you.
Okay.
Good afternoon, Ajay and Roxana. Thank you for joining us here in Atlanta. We have a really exciting case today. This is something that Emory is really proud of. We have a program for hybrid revascularization where the surgical portion is done with a robotic Lima to LAD, and then the second stage done by our interventional team. And today I am joined by an exceptional interventional team, Dr. Bill Nicholson, who recently joined us, as well as Wissam Jabber. And they'll be taking you through the second stage of this patient's revascularization. I'm going to turn it over to Mohammed, one of our graduating fellows, who's going to tell you a little bit about this case.
Hello, everyone. Thank you very much for having us. Next slide, please. So we have here a 68-year-old lady. She has multiple comorbidities, hypertension, tobacco abuse, and carotid stenosis, and had endarterectomy. She has been experiencing ongoing exertional chest pain with shortness of breath. Her EF is 45, and she had a cath done elsewhere. Next slide, please. As we appreciate here, she has a CTO of the right coronary artery, and she has a significant LAD stenosis. Next slide. So we, after the heart team approach, we decided to proceed with a robotic lima to the LAD and to fix her CTO with PCI.
Thank you, Mohammed. Good afternoon, good evening, everybody. Wissam Jabir here. Thank you for having us with you on this course. I want to thank also our staff here in the cath lab, Lorna, Michael, Elsa, Margaret, Star. We have, with the patient here today is, I know we have calcified, we're talking about calcified lesions, but the patient today end up being very interesting. There's a lot of teaching points that we're going to learn today from the team. Can we put the slides again? Just a quick thing here. We talked about hybrid revascularization. We like it a lot because it gives us the advantage of having a lima to the LAD, and then we put stents to the other vessels, which may have longer, we do probably have longer longevity than SVGs. This is the setup usually. Just a quick slide here to show the setup that we do here. We have 2 robotic arms and a scope for visualization. Next, please. So the initial step is to harvest the lima with the robotic arms. You can see it here being harvested. Next step is to expose the LAD. You see that LED here being exposed robotically. Next, please. See the LED diagonal. The surgeon can identify them with the scope. Next. Once that's done, then the surgeon makes a tiny incision, about 3 to 4 centimeters, between the ribs, lateral to the nipple, where the LED is. Next, please. And then anastomosis is done, off pump, and the chest is closed. Next, please. The advantage also is patient ends up with a small scar. There's no risk of sternotomy, sternal infections. Our practice, we typically do the intervention next day. Here, her bypass was done earlier. Because of COVID, we had to delay her PCI, and she's coming now for PCI of the right coronary artery. She still has angina, so we're going to go ahead. And I'm going to turn it over to Bill here, who has been working hard at getting this set up pictures. We're going to show you these now. Thank you, Bill.
Yeah, thanks as well. It's a privilege to be down here at Emory, privilege to be invited. So, is that you, Ajay?
Great to see you, Bill. That's me.
Yeah, you too.
Yeah, it's good.
Yeah,
the COVID pandemic made the CTO more chronic, so that's okay.
Yes, that's right. That's right. Yeah. Had some time for that calcification to develop that we wanted. So I'm going to show you here. This is a real, I think, interesting case from a lot of perspectives. I think there's a lot of strategies that could be debated and a lot of risk reward benefits that could be debated as well. This is just to show that Dr. Halkos, who's a real talented surgeon, did a beautiful job on the robotic lima. You know, it's not real redundant. It's beautiful anastomosis and great flow distally. You can see she's got that big apical LAD to PDA collateral, epicardial collateral. Very tortuous, but good caliber and good size. It would be a challenging collateral to use. We've used apical LAD to PDA connections a lot, but even though this is bigger, sometimes these bigger ones are a little bit more refractory to giving up their bends, and you can get into a little bit more trouble. So just thinking about the cases we're going, but you can see it reconstitutes the right past the PLV PDA bifurcation. I'll pause that for you and show you there. If you look, you can see the body of the right heading north there. So we shot this, and then we pulled that out and put a guide. We're right wrist, right groin. We put a guide in the LAD, and so that's an EBU 3.5. Put a wire down just to sort of stabilize things so we could get some dual injections. You can see there looks like there's some inviting septals, a lot of tortuosity to those septals, and so they become rather epicardial-ish. And so this is our sort of setup shot, and you can see, you've got pretty good distal filling. We think it's just one CTO. We think it's connected downstream, so it's not a terribly long CTO, but the cap certainly is ambiguous. And if you look at the cap, we think it's taking off right where that RV marginal kind of hooks out to the far right side of the screen. It's pretty common, just for general knowledge, that the cap is usually, the residual cap is almost always 180 degrees opposite of the side branch. So if you're looking for the cap that's left, if you have a side branch, go 180 degrees opposite, and that's usually where your spot is. We thought we could maybe do IVUS guided cap puncture here, which we passed a wire down that RV marginal, thinking that we'd be able to get the IVUS, but the caliber and the tortuosity of the RV marginal is just too large to accommodate the IVUS. And so I'm curious, with today's sort of CTO strategies, what people's thoughts would be here. We thought IVUS guided cap puncture would be nice. We also thought that we're pretty experienced at finding caps when you can't necessarily see them, that we thought we could probably find it with a wire and engage it. But that fact that it is ambiguous, brings into the discussion, would you transition to antegrade dissection reentry right away by doing some sort of modified complex case technique approximately to start a dissection, or would people just defer to retrograde right off the bat? And I'll listen to what your thoughts are. We got started a little bit early just because we wanted to get some things done and figure out what we could show and couldn't show. So we've kind of gone through some steps, but you're happy to walk us through what your thoughts are.
Well, Bill, I think that it's a great case.
Go ahead.
And, that not only is it ambiguous, but that tortuosity there, and it gives a sense of that bend, can sometimes be a little bit treacherous. So, you're in your hands, it's a little bit different than other folks just poking in that way. But for me, I think that trying to go opposite where that other branch would be a reasonable strategy. And then I probably would opt to do some sort of scratch and go or balloon the proximal and see if you can get into some plane to at least start something to be able to find the vessel. It is nice, though, so soon after the cabbage that the native LED hasn't shut down. So you have access to the septals and you don't have to compromise anything dealing with the lima or think about that epicardial collateral. So as you said, it's a pretty interesting case as a whole. I was curious, one thing for the surgeon maybe, if you had to go through that lima and around the apex, how soon should we wait after the anastomosis to start instrumenting?
Could you hear that, Kendra?
Yeah, I can.
Kendra.
Yeah. So, I think it's an interesting question. I think that one part of the answer is as long as possible. But the reality is, if the patient is particularly symptomatic, then I would say that the minimum that I would feel comfortable is probably 30 days. What does Dr. Halquist tell you guys?
I don't know. We've really had the situation come up that we've had to stress an anastomosis and concern about, are you going to lift something up or disrupt something? But I think 30 days sounds like a pretty reasonable time. And it's a CTO. It's a CTO. You can wait.
And we typically don't take the limas. We typically have other ways to do it. Sorry.
Is that Roxana?
Yeah.
Yeah, Bill. I think this is a great question, Ajay, and I would be very, very careful about going near, especially with these brand new lima and off pump surgery. And very early on, a couple of decades ago, we did the patency outcome and economics of mid-cab, and we were seeing early angiography off pump angiography, seeing a little bit of haziness, etc. And this is just the healing process of the anastomosis, of the lima anastomosis, and it really 30 days is the minimum. I would like to wait at least 6 months to allow for the full healing of that most important lifeline to this patient, which is the lima to the LAD. And then on the approach to this CTO, I think Ajay makes a great point that the good thing about this early angiography is that you still have the LAD open, and your retrograde plane could easily be used, hopefully, without any kind of a major situation or an issue. One of the things about the retrograde, though, would be you'd have to be very careful about not propagating or messing up the new lima when you're going retrograde through those channels. And I think that would be another kind of a question on how you would approach. So I would be wanting to go towards retrograde. I just find this this proximal cap very ambiguous. I really can't tell where and which direction you would be going, and I think it would be kind of surfing a little bit before you'd find something there, and that might be a dangerous situation. I wonder what Holger and other people and Azeem think on the panel. Any other additional thoughts, or Joost? Additional thoughts on this?
Holger?
Yes. Yeah, I think it's a good idea to try to do this hybrid approach. So probably we can also learn a lot on this specific case. Nevertheless, I'm not sure if you told the patient, in case you are not able to reopen the RCA, the CTO of the RCA, what is your strategy then? So this is probably something what you will have to tell the patient upfront before you go to surgery, and also for this hybrid approach.
Not with Nicholson there.
Yeah, I would agree. It's probably something you have to tell them. But you know, there's also CTOs and there's CTOs. I mean, if you have a calcified 90 millimeter CTO, and you know, you might switch your strategies. And we had a very active hybrid program back at my previous institution. And so if I thought there was a legitimate chance of failure and not having a success on a second attempt, we would try the CTO first. And if we were unsuccessful, then instead of a hybrid approach, just do full cabbage. And that worked out well. It's pretty seldom in today's day and age that you can't get a CTO, especially if you get a second shot at it.
So
that being said, we'll probably fail right here. So that's good.
I saw this patient before, and I thought that the RCA CTO should has a very good success rate in our hands here. And so going for the Lima first is not a bad idea. We could put an SVG to an RCA that's diseased, and I think the failure rate of the SVG would be higher than the failure rate of a PCI of the CTO.
In the interest of time, I think you're going to go back to
go
elsewhere in a few minutes. So let me just sort of show you what we did and where we're at. So, you know, one thing I would say, trying to find that cap when it is ambiguous, you know, the things you look for on IVUS to really kind of locate that cap is a change in caliber of the vessel size. And so that kind of is a big indicator where you should be searching for the cap. We didn't have the luxury of being able to get the IVUS out there, but you can see where this vessel goes from 2.5, 3.0 down to about 2.20, 2.25, somewhere in that range. So right at that curve of the wire, the initial curve of the wire, is where I'm thinking the cap's going to be. And I like to try to engage the cap with a jacketed, relatively stiff wire. So I used a Mongo wire here, which is a 3.1 gram wire. And I'll show you, we did shoot some pictures of the septals. I'm going to skip by that. But you can see that Mongo wire kind of penetrated right at that spot. Now this is a little dangerous, and I would be more inclined to do this with a Mongo wire than I would with a Confianza, because a Confianza or a sharp non-jacketed wire will exit the vessel. The Mongo wire, the jacketed wires, Pilot 200s, Mongos, they will stay with the vessel. They may get subintimal and dissect, but they aren't going to exit the same way. So I would not trust or chase that wire if it was a tapered tip non-jacketed wire. But you can see what we've got there now. So we've got a stain downstream. So I think it's pretty clear that wire is not in a true lumen. I think it is with the true vessel. So I think it is with the vessel. I just think it's subintimal. And so at this point, you kind of got to make a decision. Obviously, you know, we can't inject any more antegrade because another antegrade injection is going to extend the hematoma. And you got to decide, are you going to convert to dissection reentry, or are you going to look at retrograde options? And our problem is most of our visualization was coming from the Lima to the LAD to see the body of that right. And now we've obviously got that out, and we've got the guide in the left system. So we're not able to see the mid-segment of the right where you'd want to do your Stingray stick reentry. So we went and we looked at retrograde options. You can see we kind of just mangled the heck out of that one. So you can see three blushes. I'll proudly show that. So that was all my doing. So we tried that septal. We moved our way down to the next septal, which is this one. And
Bill,
this is go ahead.
I was going to say, did you think about switching your guide to the Lima to sort of see if you could then get a reentry site, or you thought the hematoma was too far downstream to make it harder?
No, so we kind of thought that for sure. You know, we sort of thought that also we had a little bit of a time crunch to see what we could get done in the time that we were going to be live. And I thought what we would do is attempt these septals, and if we couldn't do them, we were going to pull this guide, go to the IMA, and do dissection reentry was the kind of plan. Right. The first septal, you know, these are very, very tortuous septals. These are almost like epicardials. These are very difficult to wire. I think the hardest ones that we try to wire. For me, the wire that I use in these is a Sewell 3. I think that anything short of that is going to mangle this pretty easily. Sewell 3 is very soft, 0.3 gram tip, crazy amount of technology. It's like 19 wires or something that make up the Sewell 3 technology. But it is the only wire that will make these turns in epicardials and turns in septals and be able to accomplish what the very challenging degree of tortuosity that exists here. And so that's what we used here. So I'm going to show you that. The way you use this, Masa Yamani, who's a great operator, taught me how to use this. He said, you know, the wire really walks itself through the septal. And so unfortunately, some of this got captured, some of it didn't. But the wire, you want to keep the tip free and keep the tip moving. and you know, he said you spin it slightly faster than your heart rate, but not as fast as the patient's, and so that gives you an idea of how much spinning and torquing you're doing, and you've got to give the wire an opportunity to do its thing. And so what you do is if it meets an impasse like it is here, we pull the wire back and we let it reapproach the segment. And so you can see we've already made it pretty far downstream from that previous spot that we were at. It's really a shame if it didn't save all that. Yeah, it didn't. So it didn't back save far enough. But we were able to, you know, with just steady patience, it probably took us about 2 minutes to do it. Yeah, you cannot do that with another wire. I'm telling you that no other wire will do that, and that's the technique you want to use. It really, it's one of those things that if you get the wire with a little bit of forward pressure, a little bit of freedom in the tip, and just let it do the work, it will find its way. It's better than we are. And so this changed everything. Obviously, this is where we just got to when y'all came to us, and so clearly now that wire, you know, has turned and gone into the PDA. So we haven't shot a follow-up picture to show that. We kind of stopped there because you were coming to us. But it's an interesting case. There's a lot of strategies that could have been employed. And I think, you know, when you get to this point, you know, the hope is, you know, once you get retrograde, it's pretty, you can see we're going to cross all the way up to the top there. I don't care that went out the RV marginal. I'm just getting as much wire purchase as possible. And we're going to drive the turnpike through. And I hear you guys saying you're going back to
I know, but I feel this is really such a crucial time. So we want to let us watch this. Can you let Rotterdam know that we want to stick
Perfect.
here? Sorry.
Yeah. So the nice thing here is, you know, we've got good guide support. That's a 3-5 in the wrist. It's really good support position. System's got to be very straight. If they can show my hands, and you've got to have your spinning on the back hand here. And you don't waste your spins. Use them when you need them. So I'm just going to slowly advance the microcatheter. We know this is a big connection, and so we're probably not even going to have to spin it at all, in which we didn't. You see it just passing through. And so we're all the way to the PDA there. So I do that in REO so you can see what the guide's doing, and you can see when you get through the septum. Once you get through the septum, get yourself back up to the point of operation, which is going to be here. And so we'll drive this microcatheter all the way up. You're always watching your guide more than anything during these.
I'll take a Mongo wire, please.
And so you see I'm spinning there a little bit to try to get it to progress. And the microcatheter will almost always go. Usually if the microcatheter won't go, it's not the microcatheter's fault. So we're going to drive it all the way up into the vertical portion. So we're sitting right there. So now we're going to have to do something to puncture the distal cap. We can certainly come down now with our antegrade wire. We know the path here. So we can see if it was the right path, and you can see my antegrade wire is kind of heading in a little bit of its own world, but come back and redirect a little bit, and we'll line these wires up and do reverse cart. Okay, so that's looking good there.
Mongo wire.
I'm going to take a Mongo wire north now from the retrograde system.
And the one thing that was nice is that when he talked about storing up his turns, you know, these microcatheters can fatigue. So the more you turn it, the more the fatigue will be. So, you know, he's been able to preserve it with minimal turning thus far. So the likelihood is he's not going to have to get another one.
That's an extremely important point. And that's what bonds the microcatheter to the wire. And you end up losing really good things that you've accomplished because you got to pull back and give it up. And I don't know where that antegrade wire is, but I'm kind of liking the retrograde wire a lot better.
Yeah.
The retrograde wire looks good.
Yeah, I think so as well. So I'm just going to spin that and try to drill it through there a bit.
And that tells you how mistaken you were with the cap, right?
And you can see, so all that stuff I said about where the cap is, you can just throw that in the garbage because that was a complete lie. So we're going to look at that antegrade and retrograde, just make sure they look like they're lined up. And we're going to ignore the microcatheter. We're going to pay attention to the other wire. They're looking pretty good. So we're going to make up that ground. Yeah, so we'll take our retrograde gear up.
It's such a beautiful example of a good reverse cart. A beautiful example.
Yeah. He may be able to wire it through the true.
They're going right up.
Yeah, and I'm actually going to back some of this antegrade gear out of the way so I don't have so much confusion as to what I'm looking at. And I agree with you, Ajay. I think we can wire it true to true just like that. Okay.
Here you are. Beautiful. I'm clapping. Can you hear my clapping?
Much appreciated.
Bill, we were saying the problem with the online meeting is that you can't hear the clapping. So, but that was awesome.
Yeah, that's right.
That was gorgeous, Bill. Beautiful.
Wow.
Thank you.
Now, Roxana, should we go back because we did see the externalization?
Yeah, if you want to go back,
and-
we'll balloon IVUS and stent and give you guys a final look.
You know, we want to hear though the steps about how you snare and what you do to get back. I think these are the kinds of simple steps we want to cover when we come back. But we'll go to Rotterdam
Absolutely.
now. Thanks.
Great, thanks, guys.
Beautiful.
Okay. So let's take an R350 if you could, please.
Here, I have it. They have already.
Yes, yes, please.
We should change this.
Oh,
Yep.
yes, that's we're going to Erasmus.
Laten we de OCT na de shockwave zien.
Hi, Nicolas. Sorry
Okay.
that there was a beautiful first part in the other room that we needed to show live. Sorry.
No problem. No
All right,
problem.
tell
That's
us
why
what
we're
you
here.
found. Tell us what you found.
Well, we had a little bit of a discussion internally about is it thrombus, is it calcium? I think there is no consensus at this point. There might be a mixture of the two, but eventually we decided not to do a rota. Why did we do that?
So why we decided not to do the rota? Yeah, there were two things. The lumen, you could see it was quite large already, and of course, if there is thrombus, then you don't want to do rotablation for distal embolization. So that's why we chose to do something else.
Yeah, and so go ahead.
Yeah, so we did shockwave in LAD, and we took a 3.512 balloon, and then we did all the 80 pulses. And maybe Quinten, you can show us the result of the shockwave balloon.
Yeah, so we did a 3.5 by 12, 80 pulses, and then did another OCT pullback. And Quinten can show it now and discuss it.
So here we are standing here in the more distal part, and I start here the OCT, and you see here the quite normal vessel, and we start here. You see here some mixed plaque here with calcium. You see here at 12 o'clock, and here is the interesting part coming. And I stop it here because here are some cracks seeing here. So you see here at 12 o'clock here, one here you see, and I play again. You see here more cracks. Of more fractures, sorry for that. A lot of calcium over here.
And there, and at least at 3 o'clock, there was some thrombus, I think.
Yeah.
There you go.
I scroll back a little bit. Yeah.
Hoppa, hoppa,
Here,
hoppa.
yeah. Here are some spots, I think.
Ajay, come on, this is thrombus, don't you
No,
think?
that's a little bit of thrombus, but that's not thrombus that would make you afraid to do after.
I must say, we couldn't see the images as well as it's showing to us now. So, I mean, I think that looks like a clot. We agree. So, what did you end up doing?
So we were pretty pleased with the lesion preparation that we achieved with this shockwave balloon, and then we proceeded just by stenting. So we proceeded with a 3.5 by 28 synergy stent. That went in nicely, and it also deployed very well and expanded very well. So maybe we can show the angio now. And that is after stenting and post-dilatation. So we post-dilated with a 4.0 non-compliant balloon, and then decided to go for another OCT just to confirm that our stent is expanded properly. And that is the last run that we have for you. The reason why we did so many OCTs was not just for educational purposes. In Rotterdam, we have a relatively low threshold for invasive imaging. Joost is leading the invasive imaging program, and we have an extensive database. It dates back from the early days, and Jurgen Lichtart has, I think, one of the most beautiful databases of OCT and IVUS. And each pullback required 8 to 10 cc's of contrast. So now we are at 140 cc's in total, and we are coming at the end of our procedure. So we believe that that is very acceptable in a patient with preserved kidney function to have a nice follow-up of what we're doing and to monitor our results. So basically, can we show the pullback, Quinten?
So we start with the distal stent edge, no excision, something.
So we have no edge dissection, and then you see that the stent is very well expanded,
yeah,
and opposed to the wall.
Yeah. We see here also behind the strut the calcium, but maybe in the ostium of the stent, it's here some struts, not here. Yeah.
Yeah, so there might be a minimum of stent under expansion at the proximal edge. I'm debating whether I need to be aggressive here because I'm quite pleased with the result.
Yeah, I mean, it looks more malopposed than under expansion, and the expansion looks good. You know, it's a really, really interesting and fascinating case. I think that what we need to get more data to figure out is from the get-go, you know, is this the shockwave balloon? Is this just the balloon itself that expanded and the shockwave was incidental to it? But I think that being able to do a case like this without having to worry about the hemodynamic perturbations of an atherectomy, without having to go through all of that, is clearly advantageous and makes this more accessible to most physicians that would be doing cases. So really, really cool demonstration with the imaging as well.
Yeah, there is one caveat though. So each time you give a shockwave therapy delivery, it takes 10 seconds. So one pulse per second. And you will remember, we have a patient with severe aortic stenosis, and this is what happened during the delivery of these pulses with the EKG. So can we briefly show that, Rakesh? So we started to see quite, and also Gothic T waves. So the patient really became ischemic after 10 seconds of inflation. Do you see the difference? And now it is recovering again.
Wow. Yes.
Yeah. So you have to be aware that when you're using shockwave in patients with poor ventricles, that can really be the inflection point and deteriorate the hemodynamics. So be careful when you use shockwave therapies also in patients with depressed LV function, and then I would definitely also consider mechanical circulatory support. So that was a little bit the message that we wanted to deliver related to this case.
Well, it's a really beautiful case. Are there any comments from our panelists? Azeem, how do you like the use of the shockwave here?
Yeah, I think the result's fantastic. We've done quite a few left mains as well with shockwave. Most patients tolerate it, but maybe you don't do as many impulses at a time as you would normally do in a right coronary artery lesion, and try and shorten that. I also had a comment in response to Ajay's comment about, how much is the balloon versus how much is the shockwave. We only inflate to 6 atmospheres here, so I think a lot of it is the shockwave. The one surprising factor, though, Ajay, is if you do imaging pre and post shockwave, you don't always see fractures in the calcium, right? And we've done many cases where we've used 80 impulses and we don't see any fractures after the shockwave. I'm not sure if somehow we're also changing the compliance of the vessel and the calcium rather than always fracturing it. And that there may be more to this mechanism of action that we haven't fully understood.
Well, it may make it more prone to fracture when you actually do dilate it with a regular balloon. If you sort of weaken it a little bit, if you weaken it and then you inflate, then it'll crack at those weakened points. So that might be the thing. But what I just don't know, and we'll need to find out, is what proportion of these cases require the shockwave part versus not. And it's a good academic question to try to sort out, and I think imaging can help, frankly. So. But this amazing demonstration, Nicolas, and I think that in addition to your clinical skill, you're obviously able to convince the patient that one side of the wrist was better than the other side of the wrist too. You're very slick, so that was great. But very, very elegant demonstration, and they'll be set up for the TAVI in a couple of weeks.
Yeah, no,
Thank
that
you.
was
So I'll be
wonderful.
seeing you
Thank
guys
you.
in a second.
See you
Thank you.
soon. Come right back. We want to see you on the panel. All right, let's go back to Emery.
The other stand.
Hi,
Hey,
Bill.
guys.
We'll see you back live, and it
How are
looks
you?
like you're almost done.
Yeah, we're just about there. We did a couple things since we were gone, so I'm gonna rewind you a bit here while Wissam keeps working. So this is where we wired true to true retrograde. We externalized that. So you see when we externalize, what we do is we drive the microcatheter, the retrograde microcatheter, up into the guide behind the wire. Let me get you back to where that was. So give me just a second here. So you can see we've got the retrograde microcatheter now going obviously down the LED through the septum, up the right, and sitting in the receiving guider. So we pulled the wire that we wired with, which in this case was a Mongo wire, and we go back with an externalizing wire. And really there's two choices, and there's probably 50-50 as far as preference around the country, and I guess around the world is R350 and RG3. I personally prefer the R350, but a lot of people prefer the RG3, and we had an RG3 here, so that's what we used. So that wire gets passed all the way out so that it basically goes in the, I'll show you here. So for most people, I think probably know this, but we'll just kind of show you the basics of it. So the wire is coming all the way through our turnpike that's sitting in the guide, goes the whole way through and pushes out the other guide, and it's sitting out here. And this is the wire that we're going to work on now. And so what we did is we went down. So most important probably step of this whole process, if you look at where people have the most disasters in retrograde CTO, it's probably right here. You've got to get that microcatheter now. Obviously the microcatheter and all your work is going to be done on the same wire at this point in time. So you can't bang your retrograde and your antegrade gear against one another. And obviously you've got to get that retrograde microcatheter downstream far enough that you can do the work you need to do. When you go to pull that microcatheter back and leave it back in the distal bed, that's when disasters happen. You can see we intentionally disengaged the left main guide, otherwise it's going to get sucked way down the LED, and so I've got that all the way out of the left main, so it has no chance to do any kind of trauma. It's on a rope, so you can always put it back in, you know, so it's no concern. I oftentimes will sit it all the way up in the arch just to make sure that I'm not going to have trouble. And so now we've got everything set up. We've got our microcatheter in the distal bed, and at this point we ballooned, and then we did IVUS. We set it on a 3.0 distally and a 3.5 proximally. It was very diseased all the way downstream, so we placed our first stent there, and we're going to come back and get back to the proximal vessel with our second stent. I think Wissam had that set up while I was babbling there. So I think we're in a good position. One stent in. Obviously, no injections. I mean, we've done no antegrade injections really since the time when we thought we engaged the proximal cap, and I was clearly wrong. We have not shot anything antegrade. I take the control syringe off the antegrade guide so we can't mistakenly do it. Can you give me a puff there if you can?
Let's bleed it. We haven't used it in a while.
Just a quick puff.
So here's the first injection where he's looking for the ostium, but that's it.
I was just going to say the same.
18.
And what size are these stents?
Those are both 3.0s. We're probably going to post the proximal one to 3.5.
Yeah. Yeah.
That was based on IVUS size.
It is. We obviously we thought it was at least 3.5 and approximately maybe even 4.0. So give us a little puff and just make sure.
3.5 balloon.
I'm still a little curious where we were with that wire, an hour ago. But
we still have to work on this.
All of them is.
The section of flaps obviously extended all the way down there, unfortunately. So that's not what we would have expected to see here. So. Wow, that's surprising.
Yeah, that's unusual. Let's balloon that.
So we're gonna give us the IVUS back.
IVUS means
the longest, 30.
So I'm sort of surprised that section flap extends all the way down
Yeah.
Yeah.
Yeah, that's that first injection you made when you thought you were in the.
Yeah, we tacked that up pretty good though. I mean, we stented downstream pretty far already. So we're gonna IVUS that and take a look and see what that looks like. It'll clean up. I mean, it's just gonna take a little bit of work downstream, but.
A little bit more balloon dilatations, and the IVUS will help.
Yes, exactly right. Yeah. And the other thing we could do right now too is to let ourselves see a little bit better. We're kind of done with the retrograde gear, and so we can reverse this case to an antegrade case and get the left system out of there, and that'll give us the freedom to inject the IMA. So I think we're going to do that.
Yeah, I think that's actually a very, very good solution now, because you don't need the other stuff, and injecting from there will allow you to determine what's going on downstream.
Where we are. Yeah.
Go ahead.
You know, sometimes in these cases where you're going to be working retrograde through the left main, but also you want the IMA for visualization, you sometimes would use 3 accesses, but you can avoid it for the most part. In this case,
I'm going to convert this right now. So give me a Turnpike 135 spiral, please.
The Turnpike.
So I'm going to reverse this now. I don't want to, because there's obviously contrast, and every time we push something down, we're going to push more hematoma down. So I don't want to. I want to reverse the case and figure out what's going on with the retrograde angiogram. As you can see, just pushing that down extended the hematoma further. So.
Yeah, I just saw it. Yeah.
So we're just going to load this on. Maybe. I turned 48 today, and now I can't see.
Listen, it's 46, 47, I think, is when it happens badly.
Yeah, it'll just fold apart. That's just going further and further, so that looks great, huh? So, so I'm going to run this all the way down.
Can you show us the angiogram, please?
Can you show us the angio? Yeah, please.
There.
And you can see what I'm doing is I'm just taking my, you can hold on to that one.
Yeah, I'll hold.
I'm just taking an antegrade turnpike all the way out. And I'm going to reverse this case. So what I'm going to do is I don't want to have a big gap. Remember how distally, how tortuous the septal was. I don't want to pull that bare wire through that septal. So I'm going to sit my turnpikes nose to nose like that. Okay, you seeing that downstream?
Yep,
and what we'll do is, so now I can pull my retrograde wire. I know I'm not pulling against the bare exposed endothelium where I'm not going to have like a cheese cutter effect. And so we're going to pull the R350 the whole way through. Again, watching the guide. It's an RG3, I'm sorry. I'm going to watch the guide and make sure that we don't accidentally pull something in that we don't want to pull in. So again, backing that left main guide out. The Sam's pulling while we're doing
Bill,
that.
Any concern about the 2 catheters locking together or having problems like that?
So that's a good question. So the ones that lock together tended to be a Corsair and a balloon. The 2 Corsairs won't. I can't get them to lock off the table. And a turnpike, I've had a hard time getting it to lock, but they're close in proximity, but I'm not banging them together. So the reason why a Corsair and a balloon would lock is the nose of the Corsair was forgiving enough that it would actually jump over top of the balloon and kind of eat the tip of the balloon, and that's when it would lock.
Right.
What do you have there?
This is pure water. Just let's do it. I was going to give you a wiggle on this.
Yeah. So,
you want to wait for the wiggle?
No, that's fine.
They have it ready.
No. So. So now I'm going to put that other wire downstream, and I don't care if it goes up the septum a little bit. You know, the more wire support that we have, the better. I'm going to back that out. Yeah, so we're going to sit there for now. I'm going to get this retrograde gear out. So again, I'm going to pull a little bit more on this retrograde, so I'm going to back that out. Usually, if you want to reseat the left guide, you sort of reseat it right here when the retrograde catheter is about mid-septum, so that gives you enough sort of support to kind of pull the guide back in. But we're going for the IMA now, so let's do that and shoot a picture before we lose our time here.
No, that's perfect. That'll be a good way to end.
That's going to be yeah. So now since I'm the only one with a brain that just thought of this, this
you have a right radial.
A straight line down.
We have a right radial, yeah.
Yeah.
All right. So.
Okay.
Yeah, so that's going to make it more interesting here. So
exchange length wire.
We should have done left radial, but
thank you.
Kills my back. So.
No, all right, what do you want to do? That's why the distal radial. The only advantage is it saves you 2 inches on your back, which can be a lot, but that's tough.
Yeah, exactly. So So I think our own real solution, I'm not going to spend the last 10 minutes watching us try to get the IMA from the right wrist because that's painful enough to do on your own time. So I think what I'd like to do is maybe try to get the IVUS all the way down there, see if we're true lumen at that bifurcation point and realize we may have to stent across the bifurcation. So let's trap this out.
One big thing, though, for the audience, though, when you have hematoma like this, is that the fact that he exchanged the wire using the microcatheter over the externalized wire is very important, because there are some people who would try to just save time and just wire from the antegrade guide, but he's got a dissection down there, and so that's going to propagate the dissection. So it's much safer to do it the way he did it. Or if you wanted another wire and you wanted to get the PL, do it with a dual lumen catheter so that you know you're in the vessel itself, because the last thing you want to do is lose access to the true lumen.
Okay.
Ready?
Yeah. I want a fresh IVUS, please. Hook up.
Give us a new IVUS.
Fresh IVUS, you said?
Twin pass to get the TIO.
Let's IVUS it first and see what we've got if we have it. If you have one, give me the IVUS you have.
We'll just take this.
So one thing with the Boston high definition IVUS, it's really nice with the resolution. It does tend to get a little, the coats of it interact when you go through a trap liner or guide liner, and it tends to make it kind of sticky and hard to push. But we've got that out of there. I was going to get a new one, but in the interest of time, we're going to see if the old one will pass easily. If it will, that'd be nice. So.
Such a good case, Bill, really giving us a lot of teaching points here.
It's an interesting case. It'd be nice if the vessel looked good, but we'll make it look good. Hope we get to do that while we're still here. But... Can you walk with me?
And also the revascularization strategy is interesting. And I would still say that the SVG versus, even if you put a third stent in, is still dealer's choice in terms of longevity.
Keep this here and disconnect it, but make sure this is going to be unsterile.
Bilateral memories, maybe.
I mean, there's plenty of data that says that this is good, you know.
No, that's what I'm saying. Is that I think that SVG
won't touch the other.
Not the thing.
Just take it out.
It's just so sad that we could get this trial completed. That they pulled the plug on the trial, on the hybrid trial, because I really do think that this just makes a great deal of sense. You're using the best of both worlds, surgery and PCI, to give the patient the best. And I think you guys have figured out how to do it. That was one of the things is sort of the, you know, which one goes first? What do you do with dual antiplatelet therapies? But I think it's a shame that we won't be able to see the answers.
And Roxana, the patients really prefer it. You know, they fast track. They don't spend a lot of time in the ICU. Oftentimes they're extubated in the operating suite immediately when they're done, and they can go, you know, straight to the floor. They're spending a very short time in the hospital, and they recover remarkably quickly. And so I think there's a lot of advantages just beyond the revascularization strategy, which I think you can get an excellent result with this hybrid approach. But from a patient standpoint, this is a very, very different thing than a full sternotomy and a 2-vessel bypass. And I agree with you. There certainly, if saphenous vein grafts are problematic, we've known that, but that's what we had. In this case, you know, doing BIMAMs would have been an option, but I think this patient's going to end up with an excellent result.
So you can see, Ajay and Roxana, we're all the way down in the PDA.
Yep, you're good.
Right, and you can see we're true lumen. It's a beautiful, clean vessel. There's no question about where we're at. So we didn't make a mistake and accidentally run in a retrograde dissection the whole way north or something. So I'm going to pull back here a little bit and see if we can kind of see. I'm really curious what it looks like at the PLV PDA bifurcation. Is there a flap blocking us from PLV?
Go there so we could see it, because there may be a, right there. You see there, right there is where you see a little hematoma there.
There's hematoma, yeah, from all the way from like 4 o'clock all the way around. So, but
I think everybody can see that. That's beautiful.
You can see the PLV coming in at 3 o'clock, and there's not a flap separating us from the PLV that I can appreciate. So I think it's all hematoma. It's just causing the issues downstream. You can see.
It may behoove you to place your distal stent, come down as distal as possible, and then pull back to seal that hematoma. You know exactly where it is by IVUS. You just used IVUS and got a great, and I think the length of that is not that long. It's probably like a 24 millimeter stent will cover that.
Bill, are you going to do that, or are you going to cut the hematoma? What do you think?
Well, that's an interesting question, and I keep getting asked to be the one to give the talk on how to manage hematoma. Maybe this is why, because I keep making them. I think so. What Ajay's referring to is a cutting balloon and an angiotome. Theoretically would kind of pop the zit and sort of release that hematoma. And I've had that work. I've had perforation with that. I've watched Bill Lombardi have a live case perforation with that. And I've also had it release all that sludge downstream and end up with kind of no flow and sort of distal embolization. So I don't know the right answer. And I've got a normal zone down there. I'm personally thinking I'm going to stent into the PDA and just
stent into the PDA.
I think you did a beautiful demonstration by IVUS that you're in you have a very clean distal artery. You know exactly where that is, and you could just put that distal end of the stent there and then come back and just make sure you measured it enough, and I think you'll seal it.
Do you need to wire the PL branch to prevent it from occluding when you put the stent in?
Pardon me, say it one more time.
I said, do you need to wire that PL branch just in case that when you put the stent in, the hematoma extends into the PL?
It's a good question. I mean, I've never really had a great feeling as to what wiring a vessel that I'm going to jail the wire and I have to wire it through my stent anyway, like rather than just tell me where the vessel is. And if it's there, it's going to be hung up with contrast, so I'm going to know where to go. So I don't know. It's 6 one way, half dozen the other. We'd have to take a twin pass or a Suzuki down there to drop a wire down there to do it. And my bias would be to just stent across it, but I know that's probably
I think we see it and there's no
highly
slab,
debatable.
So.
And I think.
Yeah. So they're telling us we got to wrap, and it's you just have shown us a fantastic case, and maybe Ajay, you've been all day long at this. Maybe you want to wrap the day. You've been a real star. So I'll turn it over to you, Ajay.
Appreciate the opportunity.
Oh no, it's been a great session, Bill. Thanks for the case. Nicolas's case was great as well. I think we can go probably show the poll result first, but thanks again to all the Emory team and as well as Erasmus team for their live cases, also to the panel too. Kendra, thanks so much.
Thank you.
Thank you, Emory. Thank you, Emory.